Thanks, GE Healthcare, for the invitation and to be able to speak here. Thanks also a lot because I was quite early in the development of one part of the CareView Insight system. And I will come also another very thankful because thanks to GE Healthcare we were able to write these very important lung protective ventilation guidelines. But first I would have to admit I have been working for a long time here in Bruges, where I was the chairman and of a large anesthesia department, intensive care and emergency care, and where we have been using the CareView Insight system and in trying to get a change in habits of the anesthesiologists using it. But yeah, we all get from time to time a little bit older, and as I'm also that, I have retired here, but I'm still now working at the university in Ghent, where I was affiliated already for a long time. So I still have some clinical practice there, and that's great, because otherwise I wouldn't be able to stand here and still talk about practical clinical aspects. I've got a lot of research support from many companies, what I have to mention here indeed. Well, before talking about lung protective ventilation guidelines, and we had already the previous speakers touching this, atelectasis is a really problem number one after anesthesia and frequently unrecognized. The reason is that while most patients will have atelectasis after general anesthesia with positive pressure ventilation, not when they are breathing spontaneously or do get local regional anesthesia only. And by simple X-ray or clinical signs, you will never able to find that out. You have to take even a CT scan or an MRI to find out there is always some atelectasis in the basal regions. Is this important? Can it be prevented? Well, it is probably important. More and more we realize that. Can it be prevented? That is still difficult to answer yes or no on this question in every patient. The classical demonstration or explanation of these atelectasis, as we all have learned and stated in many textbooks, well, if we from awake to general anesthesia, we get a relaxation of the muscles, compression of the abdomen, loss of tone, and there is compression of the lungs, more on the basal part, where we will see atelectasis. Well, I didn't understand that for a long time, and no one really was able to explain me the physiology of that, although if you're in training and you're learning, you have to do that. But there is a problem in the explanation that is not very clear. Why is suddenly, when we are mechanical ventilation patients, we're having this problem? Well, the solve is just give PEEP, do recruitment, and we reopen the lungs, and everything should be resolved. Well, Heiden Stierma, Göring Heiden Stierma for a long time already, and it's a pity he passed away during the COVID. He already mentioned that high oxygen concentrations shouldn't be given and should be really avoided because there is something like airway closure. He came up for the first time with that term. Now, Paolo Pelosi, who also passed away, and just after the COVID for other reasons, and it's a real pity, he also wrote a commentary here, airway closure, it might be the silent killer of the peripheral airways, explaining the atelectasis. Although on the moment he wrote it, he was not physiologically aware what the exact mechanisms were, and even a few months before he passed away, I had a great discussion with him on one of the meetings in discussing how is this really working, and we finally came down to the concept of collapsible tubes. And the aspect of collapsible tubes was already discussed by my promoter many years ago, Noorder Graaf. That was my promoter with whom I did my PhD thesis on the lung and on the heart physiology and the mathematical equations. He wrote already in 1972 the full explanation when vessels collapse. Collapsible tubes like now if we apply the same aspect now to the peripheral airways, we can really explain what is happening. And what is happening is that during positive pressure ventilation, we create a positive pressure in the pleura while it is normally negative. And this positive pleural pressure compresses the peripheral airways. They are so small, are collapsible, just like veins. And in the basal parts, on top of the pleural pressure, there's the pressure of the lung tissue. And so if there is some lung edema, the pressure is even higher. But even a healthy lung has some lung tissue, a pressure of around up to 7 centimeters of water standing, 3 centimeters when you're laying flat. Lung tissue plus pleural pressure, and you get an obstruction of the peripheral airway just before the alveolar tree. And by that, we get a problem of hyperinflation first, not atelectasis. But the trouble now happens, like Hayden Stierman was telling, if this is 100% oxygen, this is in 5 minutes fully absorbed by the circulation that is still going on around, certainly in the basal parts, and then you get full atelectasis and very difficult to reopen it. So the recommendations we wrote in the lung protective ventilation guidelines before we even understood this company was maximum 40% oxygen, because then the absorption will be delayed and you might have the possibility to reopen it a lot easier. But if you're at 100%, it's in 5 minutes, and then you have total atelectasis. So what you see is, initially you get hyperinflation of the basal parts, followed by atelectasis. The faster, the higher the oxygen concentration. So absorption atelectasis is indeed happening, but after peripheral airway occlusion. And now these concepts start gaining more interest. Some people start talking already, writing it, but it's extremely difficult to prove that by measurements. Some of the difficulties I'm playing with, and I hope in the coming years to get that solved. I was given a comment on why do we not measure transpulmonary pressures as an idea to be able to set our PEEP level on the right path. Well, look, this is a patient of 2 years ago, and I was presented that at the European Society also. Is a patient in an obese, Trendelenburg position under robot surgery. And what you see is here we measured the pleural pressure, or indeed we measured the esophageal pressure, and the esophageal pressure is always 7 centimeters higher, so we take that off of the esophageal pressure, except when the patient is on the side. And if we measure then the transpleural pressure, what we see is here that most of the time, even at PEEP levels up to 10, the transpleural pressure is negative. Now, if the transpleural pressure is negative, this is impossible in physical terms. It means there's something wrong, or, and that's the fact, we are not measuring the alveolar pressure, but we are measuring the airway pressure that is disconnected from the alveoli. So, like during the inspiration, the expiration, we have a peripheral airway closure. We measure the airway pressure, we assume this is the alveolar pressure, and we see the difference with the esophageal or the pleural pressure. And if this is negative, it's because the alveolar pressure is still high, while the airway pressure is already 0 or a PEEP of 5 or 10. And it's only and when we start recruiting, and in this maneuver we were doing a recruitment maneuver 5, 10, 15, up to 20 centimeters of PEEP, we see that before the long recruitment, we had to go up to 17 centimeter and expiration before we were able to get these peripheral airways open, or at least have no negative transpulmonary pressures anymore. During end of inspiration, it's also happening, although the pressure in the airways is already high, but we had to go here to pressure of 14. After a long recruitment, we have reopened everything, and we see that we have here up to pressure of 8 inspiration, but expiration a pressure of 12 still required to keep a connection with the alveoli and measuring transpleural pressures correctly. Bottom line of this, peripheral airway pressure exists. Measuring transpleural pressures are only sensible as long as there is no collapse, because otherwise it doesn't really make sense, but we should work on that aspect. Now, before that, and that's where the third reason why I should actually thank GE Healthcare, because we had the idea there are already publications, but there are no good recommendations on what to do intraoperative regarding the prevention of lung atelectasis or prevention of the pulmonary postoperative complications. Didn't have all the equipment and the forces, so I was very happy to have Young joining us from Duke University and with all his team to get all the literature reviewed. And we met together with many others, like you can see here. Pelosi was also part of it. Hayden Stirner couldn't join, Marcel Gama-Abreu, and many other experts in this field, sitting together, looking to the literature, and then deciding what is valuable to put in the guidelines and what not. It was very extensive, a lot of work to get there. And we wrote 26 questions, and you have seen already some of the results, so I will not go through all of them. But on each of them, we said, what's the quality of the evidence, and what's the strength of the recommendation? Quality of the evidence is, are there publications, randomized controlled trial showing that? And is there a recommendation to apply that? Quite saying that is according to the experts, and then still we had that's still what the consensus is, because not every one of us always agree on that or say this is not insufficient data, or I don't think. And you can see here that the use of low tidal volume, we had a quite strong recommendation, not the maximum quality of incident. Not every one of us agreed on being this very importantly. And you might see that the fact is that under the current conditions, yes, low tidal volume is quite important, but if we might go in the future to constant flow ventilation, this might not be necessary anymore, but this data we don't have yet available on that. Opioid PEEP and recruit may improve. We didn't say should be used or should improve, because again, it is not an absolute aspect on that. But what we all were 100% in agreement, more a statement and quality of evidence, is that the formation of pericardial atelectasis is an important factor in the development of postoperative pulmonary complications. So this is indeed a big problem. We had all these recommendations all together. I would like just to force them in these 26 recommendations in 10 points. We've managed to already discuss the induction phase, very important. But we discussed that even the emergence for anesthesia may be the most important phase at all, where we didn't put sufficient attention yet. And the reason why even the application of lung protective ventilation guidelines in many centers didn't give the change in outcome in the patients, seeing that still a lot have atelectasis, and probably it's because that the emergence of anesthesia, like in most cities, was not done according to the rules we wrote down at that time. Avoid suction of endotracheal tube. This is something you should never do, certainly at the end of the extubation, but very important, you should have a full reversion of the neuromuscular block. At that time we wrote 90%. Today we should write 100% if we use the acceleromegraphy, or 90% if we use the electromyography. No opioids at the end, because if you give opioids at the end, you also will have a decline in the respiratory rate in the deep breathing, and you will again get atelectasis, even if all the other aspects were well done. No sedatives. And then, extremely important, the low oxygen fraction. The most important moment is the moment when you extubate the patient. Although we all have learned, and I've learned to use 100% or even 80% at the end of the extubation, because once you take the tube out, you will gain a little bit more time if you run in troubles. But that may be for 1 or 2 patients, but that means that 99% of the patients we extubate with a low oxygen fraction, still with some peripheral airway closure at some point, rapid reabsorption, and again, atelectasis. So it is so important. I thought this was important for obese patients, but when we sat together, we realized this is a guideline for every patient, not only the obese patients, only the patient who got laparoscopy. Every patient, we should maximum use 40% of oxygen. Now we said, in case you really said this was a very difficult intubation, and I'm absolutely afraid that I will not be able to reintubate if it is needed, we said, if you want to use a higher oxygen fraction, then you should give CPAP for 2 hours with just room air to keep these lungs open and be able to get 100 or 80% oxygen replaced by nitrous. But this is quite a lot of work, not easy, also for the patient not really acceptable to have a CPAP mask with just room air to get this problem solved. Much easier is to use 40% of oxygen. Still, I see a lot of centers, and some of my colleagues, not doing this aspect. Even when we train them, or you tell them out, you should do this, many are not using that. And that's where we said, well, to get these guidelines really working, it's not sufficient to train them, not sufficient to tell them how important they are. We should just measure the way we are working and show everyone the way he or she is working so that they can adapt he or him themselves. Also, extubate in the beach chair, under CPAP, and the beach chair, not only for the obese, for every patient, under CPAP, because under CPAP or pressure support breathing, where you lower the support to almost zero, then you only have CPAP. With the CPAP, we keep these lungs more open with 40% oxygen. That means we will have less atelectasis. And it are these points where most of the studies looking in the analysis have failed and have shown that after 2-3 hours, again, everyone has atelectasis. And then the reason is, the follow-up is, you don't need to give any oxygen supplementary anymore in a routine way. And what we found was that we needed oxygen in 90% of the patients, and once we apply this approach and also reduce the opioids and the full reversal, I hardly needed to give oxygen to patients post-operative, even after laparoscopy in obese patients, patients with OSAS and so on. The need for oxygen was dramatically reduced. It was really exceptional. It was even at the moment you want to give an opioid because there was pain and you were giving some or morphine or pyritramine, then you still needed to give some oxygen because the patient was breathing less, more superficial, and again might go in some kind of atelectasis. So we know the essential of lung protective ventilation, but we do apply it every day in every patient. There are 26 points, that's really a lot, but some of these can be monitored by the ventilator automatically, like the tidal volume, the reduced driving pressure, the PEEP, the lung recruitment when the compliance is getting low, the permissive hypercapnia also, or avoiding the hyperventilation, and the compliance, how is that changing according to, these are all data that are available in the ventilator automatically. Some of the data is not available, but at least these are available. And that's why GE Healthcare really found out this is such an important aspect. Let's make an automatic recording system telling us what we are doing. Even if we are aware of these guidelines, we will be able to check if we are applying that as it is. And what we found out when we installed this, indeed, we found initially a disaster, although many were already aware, a disaster. Everyone was still using 80% oxygen, almost no recruitments were done, PEEP levels were low, and so on. Then we explained the importance of the guidelines, in detail to the residents and to the staff members, but still very slowly people started to change. They say, yes, I know, yes, I will do, but next case, or not today, when it's calm and whatever. And so what we found out was that the importance of having this monitoring system, we found out already that in patients with a dynamic compliance of the total respiratory system less than 40, we had 50% of the cases got a lung recruitment. That's still not enough. But those who ended up with a higher compliance at the end of surgery, there were more lung recruitments done. So this was proving that doing a lung recruitment, certainly also at the end of the procedure, get a higher compliance, dynamic compliance in these patients. We have been evaluated that patients who had after induction a low compliance and had no change in compliance when no was done, that was typically different from those who had already a high value. So those with a high dynamic compliance, they don't really need to do recruitment. This was something that is not included yet in the overview dashboard, although when you go deeper in the data, you can find out that the patients with a low compliance to start off, at least 40 is a rough number for an adult, makes sense to go in that value aspect. So we think that we know most of the rules, but actually, when you go in detail, only 50% knows exactly the rules. And of those, we do not accept all the rules to be true. And if you end up that we assume that we apply them of only 50%, you end up that we hardly are following the rules that are set. And that's why we need a system that monitors, measures, and brings us back to our face the way you are working yourself in the hospital. And that's what they've said in hospital. We should start evaluating, getting a change in habits, but how are we going to do? So what we have to do is show the effect of one item on outcome in studies, like reducing the tidal volume, like doing always a recruitment maneuver, but start with only one, discuss on that, and agree that it is important and that we want to change this in our system. And then you measure the actual situation. So what we have here is a study showing that low tidal volume reduces infections and acute lung injury in lung procedures. So we have some hard data showing that smaller tidal volumes are important. So, and everyone agree on that, yes, we will go for that. Then you show the effect of low tidal on the outcome. And then we first measure the actual situation on that aspect. And the care view is great because he measures that automatically for a few months. And then we can bring the data back and show and say, how are we doing? And then you will see like, okay, the tidal volume is on the average around 7 milliliters per kilogram, but there's a huge amount of patients that get huge tidal volume still, while probably there was no absolute need, with huge high driving pressures, and a lot of patients have really hyperventilated to very low end tidal CO2s. The care view is only looking to the patients under positive pressure ventilation, pressure controlled or volume controlled, not the one who are breathing spontaneously or on pressure support, because their data of compliance and driving pressure makes no sense at all. And it's great. So these cases are not taken into account automatically, so we don't have to exclude them manually. And so we show them the data and say, look, guys, we are not doing very well, and I have I have not that much time anymore, but no problem. So we show the actually discuss, and we define what is needed to follow on that aspect. And that means that we provide also support. So let's learn how can you reduce what end-tidal CO2 do we accept also during laparoscopy? Can we not prevent and protect the peritoneum to avoid the absorption? That's another aspect. Then we can still keep the tidal volume low, and then stimulate to perform that and measure how well we've done. And after the tidal volume, you continue with the oxygen fraction, or then you go with the PEEP, and we go with the lung recruitment and whatever. And this approach allows to improve, and as you can see here, we don't have that much high tidal volumes anymore. The driving pressure is still from time to time high end, but sometimes it is like that in morbid obese patients in Trendelenburg position. The PEEP level did increase already, and we have not that zero PEEP anymore. That's great. So everyone gets some PEEP. And tidal CO2, okay, there are still some, but most are close here around the 30, 40. We can still make an improvement here. Recruitment is not very well done either yet, so still a lot of improvement possible in that situation. It's essential to have a recording of what we are doing and to show it to each other. And it should be simple to work with, automatic recorded in the background. It's so important. The care view station is recording without touching any key point, any touch point. It's all done automatically. And that's a very important aspect, because digitalization in the world today is a workload is dramatically, because we are now treating more the computer than treating the patient. So I see a lot of answers after the computer filling all the data. I did give this drug, I did that, I had an intubation, I did control the cuff pressure, I controlled the iron, whatever. So much work to put all in. So digital environment is not always simple and easy, but this is automatic. And that's a real difference. Okay, and then we start improving. You see already that we start doing more recruitment maneuvers, more after induction, still not enough after immersions. And by showing this data, this is even the most important moment. If you recruit, it should be at the end, and it should be with the cases where the compliance, dynamic compliance is less. And by that, you see the compliance drop is less, but it's still not increasing, so it is always lower than where we started off. So it is possible. We need help to succeed on that. The guidelines supported by research studies are very important. We have to sit together to decide and to improve on one step by step. Staff meeting on the quality improvement, measure the actual state, show the new state, and stimulate change, announce the measure against next month, and go further on that. That we have seen already. So it is an automatic database registration. It registrates all ventilator data and collects it in the cloud. We have seen already displays at low resolution without waveforms with the live system. It doesn't include other monitor data. That's a little bit a pity. It doesn't collect all the long protective ventilation guys, but that is not possible at all. And it is not an alarm or central monitoring control system. At least the long protective ventilation guide, the live system is that. And it really is supporting to help change your behavior. Is the most difficult thing to get that done. You need to know your behavior. You have to agree on that you want to change your behavior. And then the best is a positive approach by appraisal and telling those who are doing it, you did a great job, continue on that, see next month your results again. And I think that following these guidelines will really become reality, and I hope it's not a dream anymore. Thank you.